Ajay is there. Ajay, unmute yourself and come in, please. Ajay is my colleague. He is the Chief of Surgical Gastroenterology at Mahatma Gandhi Medical College Hospital. There is a question in the chat box. Pradeep, maybe you can take that and then Ajay can give some comments. Ajay, unmute कर लो आप अपने को.
Myself. I have unmuted. I think Dr. Rabila can take that question. Any
Pradeep, can
recommendation on the type of irrigation?
Yeah.
So the question is from Dr. Jyoti Kharel. Any recommendation on the type of irrigation fluid, temperature, volume, rate, intermittent or continuous, and what is the end point?
Yeah, so it is a room temperature. We use a normal saline, and the recommended is about a continuous irrigation for 4 to 5 days, and that will lead to about 40 to 50 liters as per the publications. But we routinely use about a liter or so, and flush it with a fast, and morning once and evening once. That's what we usually use, and we continue for about a week or 10 days usually what we use it. And the end point obviously is, if you don't find much of a debris coming out, is an end point. So as long as the debris is coming, we continue to use it. And we have not found any residual collections by using this. Probably if you use a high volume of fluid, probably some of the fluid might seep into areas and they might get loculated and they might get secondary infected. That might be the reason. But we are comfortable with using about liter in the morning and liter in the evening, twice a day is our policy.
Ajay?
Yes, sir. I think very rightly said by Dr. Pradeep. This is exactly what every resident learns during his residency time. That whenever you are irrigating with the fluid, you go for the round, you go and see the patient, just flush it with a volume, say something around 200, 300 ml volume, and you will find some coagulum or the necrotic material coming out through the drain. So this implies that you need more irrigation right now. So you can't end the irrigation at this point in time. So as long as the coagulum or this necrotic material is coming, you need to irrigate. Some of the points I think which
can I make a point?
Yes, sir. Please.
Yeah, please go ahead, Ajay. Please.
Ajay, go ahead.
So some of the important things, say, sir has said that about pancreatic fistula. I think the pancreatic fistula rate is same whether you do it by laparoscopic or open. It is because of the ductal disruption which happens with both. And the pancreatic insufficiency is also a characteristic of the necrotic tissue. How much of necrosis is there? The most important part, I think, was Dr. Pradeep has very validly said is that this open has a role either in the initial period when you want to decrease the compartment syndrome, or when you have a complication, whether it is colonic or if you need a feeding jejunostomy. I think, Dr. Pradeep, that's what is the consensus right now.
Yes, yes.
So these. And if you have a bowel ischemia or a bowel involvement, laparoscopy is a disaster, because then irrigating the entire peritoneal cavity with the necrotic tissue as well as with the enteric content becomes a nightmare, because then it will form multiple pockets of collection, especially in the pelvis, which are difficult to be managed. Next important.
Although we have discussed about colonic involvement, but can you, for the sake of students and young surgeons, can you please highlight the importance of colonic involvement and the role of diverting ileostomy?
Sorry.
So we do find sometimes this colonic communication might be obvious if you do a cologram, but sometimes it's very difficult. You might not be able to document it. These communications might be very minimal. So if you find that a lot of gas which cannot be explained, or if there is a dilatation of the colon proximal to the splenic flexure, and or unusually the patient has a loose motions which cannot be explained with antibiotic induced diarrhea, so we have a high degree of suspicions. Though we err on the side of creating an ileostomy, and and most of our patients have done very well with that. So many times it might not be easy to document the communication, because these communications might be very small. But sometimes you might be able to, if you do a cologram in these patients, you might document a fistula.
Yes. So three things which are actually available with only with open and never available with laparoscopy, we have to understand is your finger,
Yes.
the spoon holder, and the suction, the plastic suction that you have. Whatever good the suction in a laparoscope may be, but these three things cannot be replaced in laparoscopic. And specifically in open surgery is required when you have multiple pockets. The multiple pockets of collection, I think they cannot be treated, whatever we may try. And in today's time, in today's era, the procedure is indicated after multiple attempts of intervention radiology, people putting a drain. So now we are intervening only when whatever possible but to be drained by a minimal invasive procedure has failed. And this is the time when there may be some role of laparoscopic or a minimal invasive or a major role of open now. So this is the area where only open can tackle it better. Do you agree with me, Dr. Pradeep and Dr. Rajesh?
I just have one comment regarding the use of pigtail catheters, because this rampant use of pigtail catheters as a step-up approach after Pantas trial is leading to a lot of disaster now. What is happening is the radiologists are putting catheters and the patients are showing initial improvement, and we are leaving at that point. And these patients subsequently, even after they show initial improvement, then they slip into sepsis and multi-organ failure. And that is the time when surgeons are called into play. And I think that is making the surgical mortality higher. If after putting a catheter, these catheters are taken care of, because it is a very labor-intensive procedure. We have published our series of around 1100 pigtail catheters in Journal of GI Surgery. And we have shown that if we use these in a proactive manner, we can actually avoid surgery in 60%, but we are not doing that. So I would caution here that if we are putting pigtail catheters, then please ensure that they are draining, and we can actually use them as irrigation catheter alone, and that can lead to definitive management itself.
I think the most important is, as Dr. Shastri has highlighted, that it's a multidisciplinary approach. I think at this point of time, when intervention is required, I think we should have a combined meeting of the interventional radiologist, the endoscopist, and the surgeon together in planning the treatment, which usually never happens. At least in our center, for the last 5-6 years, we started, it is mandatory that we discuss, the surgeon, the endoscopist, and discuss and plan the management so that everybody is on the same page. So that's most important if you want to achieve good results. But even then, sometimes it's very difficult to get all of them onto the same page and agree to a protocol or a diagnosis.
No, Dr. Pradeep, I'm making a different point. What I'm saying is that this use of pigtail catheters, and these patients then gets referred to your center. And most of these patients then have already developed multi-organ failure.
Yes.
And that window period of surgical intervention has been lost.
If I remember correctly, yesterday there was a discussion, and it was very rightly said by Dr. I forgot who was telling this, that daily it should be a combined, daily or at least on alternate day, a medical person, a surgical person, a critical care person, intervention radiologist should see daily. It can't happen that the intervention radiologist say suddenly, "Ab aap le lo isko, kal se aapka." It can't happen. I think that is a wrong approach. Or a surgical or a medical gastroenterologist says, "हमने बहुत डाल लिया है, अब नहीं होगा, अब आप surgery करो इसका." I think that is a wrong approach. Better approach is all the three of them combinedly take it up daily basis, and then take a consensus statement. And the surgeon says, "नहीं, अब आप और मत करो. Now let me do it. I can handle it better now." At least at some point in time, surgeon should have a say. Surgeon should not be at a mercy कि अब आप संभालो.
No, even the Panther trial itself very categorically said that after a drain is put, after 48 to 72 hours, if there is no improvement in the clinical condition. So they are not looking at any radiology, they are just looking at clinical condition. If after 48 to 72 hours there is no improvement, re-image these patients, see if there is undrained collection, put another catheter. Again, see after 48 to 72 hours, if there is nothing which is drainable, patient continues to be in sepsis, this is a time to deal with this solid necrosum which has not been dealt with. So, this is a continuous care. It is not that, I have strong reservation about the way these patients are dealt with. This is not
Are referred
Last 5 minutes, Dr. Shastri's.
I think it's important to view all these techniques in their proper perspective. Comparisons are difficult because of the high heterogeneity of the patients and the clinical situation itself. The number of necrotic areas, the locations of the necrotic areas, the skill sets, the available expertise. See, all these matter considerably. So my advice to the junior colleagues is not to get confused or influenced by biased comparisons. You know, there is bound to be some bias when you are talking, you know, exclusively or say a open necrosectomy or a percutaneous approach or an endoscopic approach, because the success would totally depend on the timing of the disease, the process, the timing of intervention, the anatomical constraints there, and the individual clinical scenario, how good is the clinical situation of the patient is. All these matter much more than, when you compare. I think these things will have to be considered, and it is quite difficult. But ultimately, what the current evidence we have to accept is the step-up approach has come to stay, and step-up approach with a percutaneous or endoscopic, followed by either minimally invasive or open, based on the expertise available and results at every stage carefully monitored. That is very important. It's not only the timing of the first intervention, but the timing of the second and third interventions are equally important, as Dr. Rajesh was mentioning. I think these are the points which you should emphasize to the junior colleagues, rather than the techniques and the successes or comparisons. Comparisons are difficult here. So these are the
One point, when they compare the results, they look at composite endpoints.
Yes.
And that composite endpoint includes pancreatic fistula.
That would be the real endpoint. Yes, after all the procedures.
And
when
pancreatic
everything else
fistula we
fails,
create.
surgery comes.
Pancreatic fistula we create. It is not a complication. That is a way of dealing with this necrosis. Idea is to save that patient in one go, in one sitting, as early as possible. So if you include that as a composite, then you show that the morbidity is higher in surgical procedure. Mortality in both PANTER, in tension, is actually lower.
The problem is, in spite of the consensus about definitions of all the clinical situations in acute pancreatitis, the range of the severity is quite different in each situation. They are not comparable still.
That is true.
Whatever the statistics may show us, the statistics may show something for a particular group of patients, but the residents and the junior colleagues should understand you have to treat this patient in this scenario and this point in time. It can't come up from the whatever is been written or the vague aspects which have been given. So this is the patient that is more important.
Okay, I think it is 8:59. I will take the last minute to thank Dr. Shastri for staying full session both days and moderating, to all the speakers, all the chairpersons. I kept watching the YouTube live. I was also a little unhappy and disappointed that the number of viewers today live was small. But as I mentioned, that yesterday's sessions already had 450 views. So I'm sure that the subscribers of Gastro University, which is the creation of Avinash Tank in Ahmedabad, and Jaipur Surgical Tutorial students probably would watch these sessions at their convenience. I think that is the way teaching is today, that we deliver and they take it when they want it, rather than one-to-one. So with that note, once again, thank you everyone, especially the guests from non-surgical departments. And once again, thanks to Avinash Tank and his team. Himanshi, are you there?
Yes, sir.
Yeah, come in. Put your camera on. Let everybody see you.
Yes.
Himanshi is the support, technical support for all the Jaipur surgical tutorial activities, and we are very grateful to her. Thank you. Thank you very
Thank you,
much.
sir.
Thank you. Thank you, everyone. We'll close the meeting. Thank you.
Yes. Thank you. Good night.
Thank you.
Good night.
Bye.